Hello, and thank you so much for attending this in-service on EMS telemedicine. Let's kick this off with an important and very relevant question. Based on your experience, education, and expertise, looking back on all the patients you have responded to and cared for, what percentage of them truly needed the resources of an emergency department for their clinical complaint? Is it 30%? 60%? More? Less? Let me ask you in a different way. How many of your patients presented with a complaint that had they been your loved one, you would have directed them somewhere other than the emergency department, like to an urgent care facility or to a primary care physician, or maybe even telemedicine? Whatever your answer was, you are not the only one thinking that the use of your emergency service is also being used for non-emergency calls. An immense amount of time and likely money has been spent researching what you could have answered in a matter of seconds, that not every patient calling 911 is suffering from a life or limb emergency. Research conducted by Jason Jones shows that non-emergency utilization of EMS is a growing issue here in the United States, and that it is negatively impacting many agencies' abilities to properly meet the demands of the communities that they serve. No secret there, right? Additionally, research from both NYU Medical Center and Johns Hopkins Medical Center also confirm what you have known for most of your career, that almost 80% of patients seeking care in an emergency department do not need an emergency department for the care they seek. Again, things that you and your profession are very aware of, but are now supported with strong data. Based on that data, along with all the above factors, the status quo is simply not sustainable. It is time to implement change that will better serve our communities, improve medical and financial outcomes for those seeking our help, and improve our availability and response times to those higher acuity patient populations. At one point in your career, you may have heard someone ask, what are the two things that emergency services hate the most? The first one is listed at the bottom of the screen: change. The second one is the way things are. Understanding that change is not always welcome and/or simple, it is imperative that we take action to restructure our service line by continuing to welcome change in areas that can improve outcomes. With that, I ask a couple things of you as we get a little deeper in this presentation. The first is to consider ditching the term pre-hospital emergency medical care provider. Not everything that we do has to be linked to a hospital outcome. This term should be considered outdated. I challenge you, as a good friend once challenged me, to consider yourself as an out-of-hospital healthcare professional. Secondly, let's talk destination-based decision-making. Our field diagnosis leads us to this decision: cardiac to cardiac centers, trauma to trauma centers, and so on. I challenge you all to consider the patient's couch as another appropriate destination. Some patients need the emergency department. Some need urgent care. Some just need to be seen and cared for at home. With all that we have discussed thus far, I thought this next video was a perfect addition. Enjoy it.
Why would you think taking Benadryl and eating shellfish is a good idea when you know you're allergic to it? All right, so you want to go to the hospital because both of your livers hurt. I really like the taste of shellfish. I mean, it worked the first 15 times. How many times? So you want me to take you to the hospital because your hands are dry? Hey, how are you back here? I just dropped you up at the hospital 15 minutes ago. Man, the wait was way too long over there, bro. So my buddy picked me up and bring me back here. No, man, we can't stop and get Taco Bell on the way to the hospital. Can you guys give me a ride over to Northwest Hospital? So you twisted your ankle yesterday at 4 p.m., but didn't call us till 3 a.m. because you didn't want to miss out on your date.
That pretty much describes those X percentage of calls that we talked about a few minutes ago, right? But what if we could improve the outcomes of those calls? What if you could bring the ED to your patient instead of the patient to the ED? What if you could be part of the conclusion of your patient's care plan instead of just a segment of? What if you could improve the patient experience and financial outcome, community appreciation of your profession, reduce out-of-service times, improve wall times and response times, and the list goes on, all by bringing the doctor to the patient virtually? This is truly patient-centered care focused on the right care in the right place at the right cost in the out-of-hospital profession of EMS. Welcome to Tele911's Virtual ER. Tele911 is an emergency medicine medical practice that was created by emergency medicine professionals who envisioned a patient-centered care model that was simple, was fast, and was less expensive than an emergency room or an urgent care visit. Focused on providing the right care in the right place at a reduced cost, our board-certified emergency medicine physicians are available 24 hours a day, 365 days a year for all patients regardless of whether they are insured or uninsured. In today's world of technology and ever-changing demands, telehealth and telemedicine are becoming standard for today's patients, creating a new team approach to improved outcomes. This team approach offers you a broader range of options for the care of your patient, not just transport to a hospital. This includes treatment in place, transport to alternative destinations like an urgent care facility, if policies and agreements exist for such, possible referrals to a PCP, urgent care or specialty care center, or even the emergency room, all by means of a personal vehicle. Maybe your agency has agreements in place for alternative transportation methods like one of our partner agencies in Texas, where they use Uber Health to better assist their patients in getting to necessary destinations without unnecessarily tying up one of their ambulances. And finally, it may be determined that EMS transport to a hospital is simply the best thing to do. Finally, let us talk about those high acuity AMAs. Maybe it's the chest pain patient or the diabetic with multiple comorbidities. Maybe it was a patient with new onset seizures. Regardless of which, they ultimately refused your expertise, therefore placing their own health and outcome at an even greater risk. Here at Tele911, we convert on average over 60% of AMAs to transports simply by providing your patient with a video consult with our physicians. This results in critical patients getting to tertiary care facilities that otherwise would not. As such, we strongly encourage the use of Tele911 for all your high-risk AMA populations. Although you have already heard this, the use of Tele911 allows for direct patient-to-physician contact, a decrease in hospital waiting room census, and improved EMS operational efficiency. Regardless of the patient complaint and/or disposition, we will conduct a follow-up with the patient within 1 business day of the initial consultation. Our patient care coordinators reach out to the patient to check their well-being. How are they feeling? If medication was prescribed, has it been picked up? Has it been taken? Regardless of how the patient is doing, we offer another medical consultation to reassess, alter medication, and so on, all to ensure healing for the patient. In the area of the wake-up diabetic, for instance, these are common RMA patient populations that you as a provider have handled flawlessly and likely without the need of a physician. We ask you to consider the benefits of our follow-up call to that patient population. Are they compliant with medications? Do they need their medication altered? Do they have a primary care physician they can check in with? If so, have they? Do they need additional care? Are there other resources that they may not be aware of? And so on. Finally, these consults should be blended into your current QI process to ensure strong, appropriate delivery of service by all parties involved. So with that, let's look at how the virtual ER works. You respond to a patient in need of your care, and upon arrival, you complete a routine assessment. Based on your findings, you determine if the patient is best cared for in an emergency room. Remember my question in the beginning? What would you do if this was your loved one? Try to make that part of your thought process when going through your assessment and field diagnosis. If yes, and the patient agrees, then continue care and implement transportation. If no, if you are unsure, or if the patient is refusing transport against your medical advice, then now is the time to connect to the virtual ER. An example of this would be, Mr. Smith, based on everything that you have shared and all that I have found in my assessment, I don't believe you need to go to the hospital to get the care you need. I'm going to bring the doctor to you right here, right now via video, and hopefully get you the care you need while avoiding the hospital. If this is an AMA, then obviously the wording is slightly different, maybe more in line with, Mr. Smith, my findings suggest you are experiencing a potential life-altering or life-threatening situation, and I'm going to connect via video with a board-certified emergency medicine physician to share their thoughts with you. Before we walk through how to initiate that consult, please don't forget what I mentioned earlier. This is a team approach to patient care. This is not a handoff or referral to the doctor, but a consult. Introduce yourself as you typically would when speaking with a doctor in the hospital and provide a summary of your situation, your findings, and your desired outcome. Following that brief interaction, you will introduce the patient to the doctor. Additionally, we have access to language services and can bring interpreters into the consultation for over 200 languages. If an interpreter is needed, simply request such from the doctor that you connect with. We will cover the next steps momentarily, but first, let us show you how to connect with us. Once you have determined that your patient meets criteria for an EMS telemedicine consult, be that with the intent to provide treatment in place or to try and convert an AMA to a transport to definitive care, open the app on your device and, if needed, log in by entering your username and password. Once you are logged in, you will see the following page. This is where you will begin entering patient-specific information and, if possible, copies of identification and insurance cards. If you are able to capture a picture of the ID card, our system will use the ID photo to populate the patient demographics, saving you time. If you don't use the photo ID function, all entries must be made manually. Once you click the box noting that you have an ID, you will be taken to this area where you can upload photos either by dragging and dropping, or in most cases by taking a photo of the ID. To do this, click on Browse, and you will be given an option to go to the device's photo library, to take a photo, or to choose from an existing file. Here we will choose to take a photo. Once we choose this, your device camera will activate, and you will proceed with capturing a clear picture of the front of the ID card. Once that is uploaded, you will move to the next section to take a photo of the back of the card. Once this is completed, please double check to ensure that the demographic information that is entered matches that from the ID, and then you can proceed to the next page. On this next page, our system will search all previously entered patients in the Tele911 system to determine if this one already exists. If this patient has been consulted previously, they will appear in a pick list. In this case, this patient appears to be new, so we will proceed by choosing the button on the right titled Create New Patient Record and proceed from there. Next, we will then be taken to the PHI section. In the first field, we will enter the chief complaint. These areas can be completed by typing or dictating. Dictation can be used by choosing the microphone on your keyboard display. The chief complaint can be as short or as long as you wish. It may consist of medically approved abbreviations or full words. Here we will simply note test. In the next field, you will see a drop-down to enter the intent or reason for visit, treatment in place, or AMA. Next, please enter the patient's phone number. This is imperative to have so that we may conduct the necessary patient follow-up. If the patient wishes to have a discharge summary provided to them, an email address is also required. Next, select gender. Enter the social security number, and if you took a photo of the ID card, confirm the patient's address information as correct. Otherwise, make necessary entries. Hit continue, and you will then be taken to the primary insurance page. Just like the patient's phone number, health insurance information is imperative for the complete success of the consultation. If you can capture a picture of the card, then fields will be populated automatically. Otherwise, please manually enter the information requested and then hit continue. This final page consists of optional fields for vital signs, temperature, pain scale, blood glucose, and patient's height and weight. If dealing with a pediatric patient, please ensure that you enter a correct weight. Hit continue and you will be taken to the Setup for Video Consultation page. You will see two options here, one for installing an app called VC and another for Proceed to Consultation. If the device has never been used before, you may need to install the VC app. If so, follow the instructions provided on the screen. Regardless, once VC is installed on the device, there is no need to ever launch it. It will launch on its own when necessary. If VC is installed, you will click on Proceed to Consultation and you will be taken here. This is the waiting room where your request will be pushed to our emergency medicine medical staff until responded to, at which time your screen will change to this, thus allowing you standard video consultation features, such as video on, video off, mute, disconnect, as well as the ability to take pictures. You will see the MD face-to-face throughout, and when you have completed the consultation, simply hang up. So as you just saw, this is a simple process. Now let us cover the potential outcomes. The doctor may provide counseling, may request EMS to provide treatment, might write a prescription for medication and/or a durable medical device. might navigate the patient to diagnostic testing, or to a PCP, or to a specialist. The patient may be referred to urgent care or to the ER by means other than ambulance, or it may be determined that EMS should indeed transport to an emergency room. Regardless of the outcome, EMS will complete their interaction with the patient, complete the PCR, as well as confirm insurance information and a contact number for the patient. Tele911 will complete any actions that we have committed to, along with the EMR, and move forward with any patient care navigation. The patient care coordinator will assist the patient with any needs, such as appointment scheduling, and will follow up with the patient within 72 hours to check their status and well-being. As a final reminder, it is crucial to obtain the patient's phone number and health insurance information. The preferred method for the insurance information is a photo of the front and back of the card uploaded via the app during the intake process. If such is not possible, the name of the insurance company, insurance ID number, policyholder, claims mailing address, and phone number on the card should be included some other way in the PCR and forwarded to Tele911. If the patient has no insurance, please note such. So you may be thinking, what are the outcomes? What value does this add? We have completed thousands of EMS telemedicine consults across multiple states, and we're proud to say that when an out-of-hospital healthcare professional, like yourself, using your education and experience, identifies a low to moderate acuity patient and chooses to initiate an EMS telemedicine consult, that on average, 80+% of those patients have remained out of the hospital while receiving the initial care, diagnosis, and follow-up that is needed to improve their health outcome. What about the high acuity AMAs that historically are left home, regardless of your attempt to convince them otherwise? Our ability to convert that patient to a transport is 60% higher than historic non-video methods with a physician, thus getting 6 or more out of the 10 to the hospital under your continued care. Maybe your concern is extended scene times. From the time you submit your request to connect with our emergency medicine physicians to the time you are face-to-face with one is on average less than 1 minute, with the average duration of that consult being less than 10 minutes. We understand that some agencies are closer to emergency department resources than others, but on average, our data shows a savings of 1 to 2 hours versus transporting to the emergency department. Also, the distance to an emergency room should have no impact on the decision-making of whether a patient needs one or not, right? They are either sick enough or injured enough to warrant the ED, or they are not. We also understand the importance in transparency and data sharing. As such, your leadership will have access to an agency-specific dashboard providing real-time data on each and every consult that is attempted, along with the outcomes of each attempt made by our patient care coordination team to provide follow-up. To assist with easing the screening process to determine which patients are eligible, we have created a medical screening checklist. These sections do undergo change from state to state, so please make sure that you are using the correct checklist for your agency, region, and state by obtaining this from your administration. Here is a short list of examples for utilization of the virtual ER. Asthma or COPD exacerbation, sprains and strains, flu-like symptoms or other sick person calls, fevers or febrile seizures, hypertension, headaches or migraines, low-risk chest pain, palpitations, and near syncope, to name a handful. This in no way covers all patient populations, so please make the decision based on your assessment and whether you feel the patient is or is not in need of emergency room resources. So those 8 to 10 minutes that we spend on video with you coordinating a care plan is only about 10% of what we do overall. Much of our remaining time is focused on follow-up from our patient navigation division. Our patient care coordinators are passionately dedicated to supporting your patients in various ways, particularly in addressing social issues that may impact their well-being. Among the areas they can assist with are coordination of transportation to and from appointments, resolving prescription issues, facilitating connections with local social workers, assistance with housing and food insecurities, and providing guidance on accessing education and healthcare insurance resources. Many uninsured patients are eligible for state Medicaid and simply don't know it or know how to get it. We assist those populations by providing direction to organizations that can assist them in applying for said insurance, thus opening them up to other resources. As we noted in the beginning of this presentation, transformation within our profession is happening. Historic EMS operations are long overdue for a significant change. The idea that every time someone calls 911 with a medical complaint, we are bound to transporting them to an emergency department is simply absurd. The list of defined appropriate destinations for our patients has consisted of 4 to 5 locations, mostly being that of the hospital. Trauma to trauma centers, stroke to stroke centers, high risk to tertiary care, low risk to community hospitals, and so on. I challenge you to add the patient's couch to your list of destinations. This partnership between Tele911 and your agency allows for just that. We understand that as a newly implemented program, there will be learning curves for all involved. With a shared focus, constructive real-time feedback, and a true teamwork approach, this will be an incredible advanced out-of-hospital tool that results in improved healthcare for all involved. I thank you for your time, and I hope that you are as excited as we are in transforming EMS from what it has been to what it should be, an out-of-hospital healthcare profession. Please reach out to us or your administration with any questions that you may have, and continue to provide incredible patient care to those trusting you and such.